Hi, everyone. I'm Tony Eskander. On behalf of the CDMS and the AHNS, just really wanted to thank all of our case presenters and discussants for tonight. The topic is thyroid cancer from simple to complex. I want to give a special shout out to Caitlin McMullen, who helped organize all of this. We've got Sita Chen presenting under the supervision of Emily Marciano. We've got Annie Thornton presenting under the supervision of Vininder Dilon, and we have Ashok Jethwa presenting for himself. And they're from UW, John Hopkins, and the University of Minnesota. Superstar lineup. We have also two fantastic expert discussants. We got Rich Wong from MSK and Valentina Tarasova from Moffitt. I'll hand it off to Caitlin.
Welcome, everybody. Thank you so much. Thank you, Tony. Thank you, JJ, for organizing to the CDMS and the endocrine section. We are going to jump right into it. We have a really cool set of cases. So thanks to our three presenters. And thanks again to Dr. Tarasova and Dr. Wong for participating tonight. I know it's late and everybody's had a long day, so I'm really grateful that y'all are here. Let's get started. So our first case comes from Sita Chen and Emily Marciano from the University of Washington. So do you guys want to start sharing?
Yes. Can everyone see the screen?
Yes. And
Yes.
as we go through the case, Sita, we may jump in and ask some questions. Dr. Wong, Dr. Tarasova, or anybody else on the call, please feel free to ask a question or chime in about something as we go through the slides, and we can have a discussion at the end. Either way, just super casual, relaxed. So let's get started. Let's get into it.
Okay, this is the case of Dr. Marciano's that we're presenting today. This is a 26-year-old female with a history of an incidentally noted thyroid nodule by her dentist. She's asymptomatic, and on presentation, she didn't have any dysphonia or dysphagia or dyspnea. She had no history of radiation exposure or any family history of thyroid cancer.
Finish, Naren.
Sorry. Oh, hey, Vinny.
Oh, sorry. Hi.
Hey, it's okay. We're doing your case next.
I'm talking to my kids. I apologize.
That's okay. Feel free to chime in anytime.
A physical exam was unremarkable. The thyroid nodule was not palpable, and her scope demonstrated normal bilateral vocal fold mobility. So her workup showed the following lab studies with normal TSH 1.552 and free T4 0.8. On her imaging, she had a right thyroid nodule that did not meet criteria for biopsy, and she had two nodules on the left that did meet criteria. One was TIRADS 5, or highly suspicious, with the biggest measurement at 1.8 centimeters, and the other, also 1.8 centimeters, was a TIRADS score of 4. The isthmus was normal, and she had no notable lymphadenopathy.
Before you move on, let's just take a look at this ultrasound. Do you want to comment a little bit on the appearance of that nodule?
Yeah, so this nodule is, I would say, mostly solid or almost completely solid. I would call it hypoechoic to the surrounding tissue and taller than wide. So based on that, this would be characterized as TIRADS 5 because there's also microcalcification speckled in throughout. And there are also punctate echogenic foci within. So this meets criteria for biopsy over the size of 1 centimeter. So they did biopsy this one.
Dr. Tarasova and Dr. Wong, do you have any other things that are jumping out to you about this nodule?
I'm always interested in its relationship with the the capsule and the strap muscles, and you can see there's a little bit of an anterior push. Nothing I would say that's overt extrathyroidal extension, but I'm always interested in the boundaries. There's a good margin there with the carotid, and then the things that are more concerning are when they're irregular or they have posterior extracapsular extension or medial extracapsular extension. Those are the more concerning ones.
Yeah, I think that is heterogeneous nodules with somewhat lobulated margins, so somewhat suspicious, not necessarily something that immediately raising high concern for cancer, but definitely something that requires biopsy in the younger patient.
I think one other thing that bothers me is the margin with the nodule on the cartilaginous structures. It's very kind of a flat and not an acute angle. There's not any cushion of normal thyroid tissue there. So these are the kinds of things that we look out for. Okay, I guess let's keep going. Thank you, Sita.
Thank you. That's great. So biopsy with FNA, the superior nodule, the ThyroidS 5 came back as malignant PTC. And the second nodule in the mid area of the thyroid came back as benign, consistent with benign follicular nodule. And so next steps, we have options, active surveillance with interval ultrasound. We have hemithyroid. We have total thyroid.
So let's talk about these options. So what kinds of things would lean you towards or away active surveillance for this patient? Sita, do you want to comment a little bit on that?
I think that based on my understanding of thyroid cancer, it's really rare that I would be offering somebody young and healthy and otherwise able to undergo surgery active surveillance. I think that with the PTC nodule, she meets criteria for at least hemi. So active surveillance might fall under the category of somebody that either cannot undergo surgery or absolutely is unwilling to undergo. But I think in this case of this young, healthy patient, it isn't something that I would necessarily offer or discuss at length. I would probably talk
sorry,
about.
Sita,
Oh,
I'm sorry, Caitlin. Maybe a good time to bring up the new guidelines on the recommendations for active surveillance, which
sure.
Or maybe we can ask one of our expert panelists to bring it in. But in my reading of it, they're pretty close on the 1 centimeter, unless there's like you have a clinical trial at your institution or something else that you're going to be working within. So I think that also kind of brings to bear in this patient.
Yeah, Dr. Teresova, do you want to comment on that a little bit?
Definitely. So active surveillance was initially introduced in 2015 guidelines and was now in 2025 ATA guidelines on differentiated thyroid cancer. Now it's endorsed as one of the recommendations for management of smaller thyroid cancers, less than 1 centimeters PT, 1A and 0. So we need to really assess the lymph nodes on the neck to ensure that there is no lymph node involvement to qualify for active surveillance. So also for smaller papillary thyroid carcinoma, now radiofrequency ablations could be considered, but it's out of the scope for that case. That case is slightly above the threshold for us to consider for biopsy, and it makes it not ideal candidate for active surveillance. Typically, from the ideal candidate will be patients with smaller, biopsy-proven papillary microcarcinomas that in all the patients, in the absence of other like in the absence of suspicious lymph nodes in the neck, then we have also to ensure that the patient is on board with active surveillance and they are interested and willing to follow without surgery. And we have an expert team who is also interested to provide, have ability to provide high quality ultrasounds for the patients. So many factors have to come together to really qualify for active surveillance. This is a little bit above the threshold that will offer active surveillance. However, there could be circumstances that, let's say if this patient will be pregnant, we'll be naturally offering active surveillance until she will deliver. So, but in general, not ideal candidate based on the age, appearance of the nodule, the size. And more workup is necessary, definitely.
Dr. Wong, I know you guys have a lot of experience with this and sometimes even larger nodules. What do you think about active surveillance in this case?
Yeah, so I agree completely with Valentina and Saida. It was really eloquently described by both of you. In this case, as you pointed out, Caitlin, it's abutting the trachea. It has this anterior push into the straps. So the location of it within the thyroid is another component that's important. The ideal candidate has a cushion of thyroid around it. The second is that this patient's really young. And if you look at the Miyauchi data, the younger they are, the more likely they are to fall out over time. Every decade increases their risk that they're going to fall out. And so in aggregate, this patient has a very high chance that she will need surgery at some point because she's so young. And we don't want her to be disappointed with that. The other thing is that if someone like this fails and they progress, it could become adherent to the trachea, it could become extrathyroidal. And then insteed of doing a hemithyroidectomy, you're suddenly talking about a total thyroidectomy. So the penalty for failed active surveillance with progression, if you select poorly, is more radical therapy in the end. They're all fine in the end, and nobody dies, but there's more radical treatment that's delivered. So I agree with everything that's been said already. At MSK, we do have guidelines for our own protocols where we accept up to 1.5 centimeters carefully selected lesions. And because we have lots of older patients here that have been through, lung cancer and colon cancer, and you find something that's 1.5 and in a good location, this guy's been through chemo and everything, and you just don't want to touch him, so we have tons of people like that here.
There's a lot of that at Moffitt too.
Yeah.
Awesome. All right. So I guess our next option there is hemithyroidectomy versus total thyroidectomy if active surveillance is not looking like the best option for this patient. So let's talk a little about that. Saida, do you want to start about the discussion?
So in discussing the options with the patient, for nodules that are on the smaller end, like often less than 1 centimeter, there's a stronger recommendation for hemithyroid, even for PTC, with the final decision dependent on the pathology after excision. From 1 to 4 centimeters, traditionally what I've learned is there's a bit of a gray area. You can offer both options, but you don't have to really push for a total thyroid unless the mass starts to go over 4 centimeters. In her case, she has a couple of concerning signs that have been discussed on her nodule based on positioning, based on the contours of the nodule, based on obviously its diagnosis as PTC. I would probably still offer her a hemithyroidectomy to start off with and see if I can achieve good margins around the tumor, see what the qualities of the nodule are after excision, and then base a decision to do a completion on what pathology results, just to try and save for some of the slight elevated morbidity of a total thyroid and go from there probably.
What are some of the risks of hemi versus total in terms of surgical side effects?
You do, of course, there is a slightly higher risk of hypocalcemia from hypoparathyroidism. I think that's the major one. Anytime that you're doing total, there's the possibility of damage to both nerves, but typically I believe surgeons will, if they lose stim, stop, wait for the nerve to come back and proceed to the other side. I think it would be very rare that you would move forward with surgery if you had suspicion that one side of the nerve was damaged.
Yeah.
I think those are the major ones that come to mind. There,
Sure.
Of course, you have to take Synthroid for the rest of your life. Patients that have a hemithyroid do have, I think, like about a 20% chance of needing a little bit of Synthroid for support. But often, if you proceed with a hemi, many of them don't need to take that additional medication.
Dr. Terasova, what's your experience for patients needing Synthroid after hemithyroidectomy for papillary?
So we usually don't stop patients who undergo lobectomy. We don't routinely start thyroid hormone, even if, let's say, their TSH is not like in the upper limit of normal, or let's say if they have Hashimoto thyroiditis to start with. This is the markers that maybe predispose them, put to them at high chance to develop low thyroid function, but we give the thyroid opportunity to catch up, and we just follow the thyroid hormone levels closely. Even if TSH is not, let's say, at goal, it's slightly above the normal range. If the patient feels well, we typically do not start thyroid hormone, and there is a pretty high chance that the thyroid will start producing appropriate amount of thyroid hormones within first 6 months. So, but if the patient is symptomatic and the thyroid hormone levels are above the normal range, so we typically start thyroid hormone, but once you start, that there's no way back, that you will not be able to discontinue it at any point. So we'll give it a chance. There's no need for, if you really commit to lobectomy, meaning that the thyroid cancer was not as at high risk, there is no need for TSH suppression if it's maybe not the lowest risk of thyroid cancer. So there is no need to start thyroid hormone to keep TSH at a lower range. That's not an indication for initiation of thyroid hormone therapy in thyroid cancer patient after lobectomy.
We usually quote patients about a 30 to 50% chance of ending up needing thyroid hormone after a lobectomy. So it's actually a bit higher than you would think.
Mhm.
Dr. Wang, what do you think about how would you approach this patient in terms of the discussion for
So,
hemithyroidectomy or total thyroidectomy?
so that was a really good discussion that we just heard, and I agree with you, Caitlin. Over time, the percentage of people that need hormone goes up. It may not be at your first post-operative visit. It may not be at 6 months. If you look at what happens in the next year or two, the percentage of people that wind up going onto it goes higher and higher, especially the people that have some degree of Hashimoto's or they already have some thyroiditis. They're kind of burning out already. You take out the other half and it doesn't have quite the capacity. But that having been said, we still really strongly prefer the lobectomies at Memorial because for whatever reason, in our experience, for the patients that undergo total thyroidectomy, there's this small but very unhappy percentage of patients that are changed irrevocably by having no thyroid tissue. In my opinion, maybe it could be like a 20% group or something like that, but these people will forever complain about fatigue, altered sleep patterns, changes in their body weight. The most common complaint is that they gain, 10, 15 pounds and they can't get rid of it anymore. And these people are changed. And we're doing everything for these people. We're putting them on BID dosing. We're doing Cytomel. We're trying all these different, we're changing brands from levothyroxine to Tyrosent. We try Armor. We do pig stuff. We do all this stuff. And for this small proportion of people with the totals, it's just hell. I just can't explain it. Now, for the lobes, I find that even if you're on hormone, if you've had a lobe, the majority of people in the end are okay. There's something about having endogenous hormone that's your own, released on your own schedule, 24/7. You know what I'm saying? Responds to your needs. It's home cooked food. It's not exactly like the synthetics. And so, while with total thyroidectomy, I'm going to admit that the majority of people are totally fine on levothyroxine. There's that small minority that are miserable that we all deal with here. And I'd be interested to hear what Valentina thinks about that. But that's the main reason that we favor lobectomy in these cases where iodine is not going to be mandated.
I think, yes, I 100% agree. Sometimes no matter what we do, and we do also in Florida similar things that you guys do in New York, including the most radical choices, but it's still some patients don't do well. But overall, most of the patients actually do pretty well. If there is no question, it's better not to be on thyroid hormone rather to be on thyroid hormone. Like if you can afford being minimalistic, it's always a better choice for the patient from any standpoint. Even commitment to the lifelong medication, need for follow-up, and regular checkups for the dose adjustment. This is all represents major lifelong implications for the patient. So if that could be avoided, that's always a better choice. But yes.
Thank you so much.
Sometimes.
That was a great conversation about the thyroid hormone supplementation, which we don't always get as trainees. And just a quick comment on hypoparathyroidism. It seems like no big deal to take calcium supplements, but these are also another very miserable group of patients, and it actually is associated with increased morbidity and mortality over time. So if you don't have to do it, don't do it. But sometimes oncologically it may be appropriate. So why don't we go to the next slide and see what happened?
Surprise, she got a hemithyroidectomy. Lesion 1 was found to be a 1.6 centimeter PTC of the classic type. There was LVI, and the margin status was focally positive at the posterior margin. Within the left thyroid lobe as well, the second lesion was found to be follicular carcinoma, minimally invasive, with no additional qualities, no LVI, PNI, and negative margin.
Oh, that's a little complicated. Okay. Wait, go back.
Oh, sorry.
Let's digest that for a second.
I think I can go back. Oh, I'm sorry.
Sorry.
You gave it away.
Spoilers.
I
don't know if I can go back.
We got all the answers.
Okay. Yeah,
Wait,
yeah.
Can you go back to the path?
Let's just pretend that.
Okay.
There you go. No, it's fine. You're good.
Yeah. It's fine.
Okay, so we've got two different types of cancer. Let's first talk about the follicular carcinoma, minimally invasive, small differentiated tumor. would any of our expert panelists recommend completion based on this tumor? No.
No.
Okay. No high-risk
No,
features here, which is great.
Yes. So the most important when we see follicular carcinoma on pathology, the most important feature that you want to look at is the presence of vascular invasion and number of foci of vascular invasion. So if it's more than 4 foci of vascular invasion, that put the patient at high risk and about more than 30% risk of recurrence. And if it's no vascular invasion, it's actually low risk based on UATA risk stratification. If it's some vascular invasion present, but less than 4 foci, that will be low intermediate risk. And typically low intermediate, that does not necessitate completion thyroidectomy. So only the patient with extensive vascular invasion, or let's say high-grade features or gross external extension, they're the ones who require completion thyroidectomy in follicular carcinomas. But just capsule invasion, no need for completion.
Okay, so that's the small follicular carcinoma. And then we have a 1.6 centimeter papillary classic type lymphatic invasion. What are your thoughts about that, Dr. Wong, Dr. Tarasova? Not making you feel too nervous, that particular feature, right?
No, because lymph node metastases are in themselves not, we see them commonly, even low volume disease, and that does not concern me. Even the focally positive posterior margin doesn't bother me. I know it may bother a lot of other people, but it really depends on how the surgery went. If your surgeon tells you that it came off cleanly, okay, and they had to dissect it off the nerve, and maybe the capsule of the tumor was breached a little bit, but it looked really clean at the end and everything looked clean, I still consider that a good resection. On the other hand, if it was really stuck and there's like a rind of granular stuff on the trachea, Caitlin, you were looking at that tracheal border. If there's like a rind of stuff there, then that's not okay. So to me, details of like how the posterior margin felt to the surgeon is important.
We try to comment in our operative notes the resection status. So, whether it's R1, R2, which means gross disease left behind, that's an important thing to consider. So,
and actually, can I make a comment?
Yeah,
because I see a lot of operative reports from Dr. McMullen, and I love that feature that she puts it in bold, all the important features that kind of change the decision making, incorporating these intraoperative reports. So if there is clinical suspicion for gross external extension, this is all in bold, so I don't have to really dissect the report well. I know that these features will be highlighted, just like a tip for more transparent communication between surgeon and endocrinologist.
Yeah, and pathologist. So everybody reads those reports, and it's important to be clear about what you found. Now, in terms of that focally positive posterior margin, so in the new guidelines, this sort of brings us into this new category, right? Low intermediate risk. So let's see what happens with the next slide, because we have already gone a few minutes over with this case. So what are our two expert discussants vote for the next step?
No, I'm going to get it wrong because I saw what happens, but
or maybe I got it wrong.
I'm going to get it wrong, but I'm going to get it wrong anyway. We would monitor here. This patient would get, serial ultrasound images, and we would follow, even though there's an attack low, we would still do TG, and we would see the patient back, and this patient's prognosis remains very, very favorable as long as the surgeon felt like the resection was clean. But I know that there's going to be controversy over this because of the low intermediate risk thing, and I get it. And people are going to feel compelled to go back and do completion for iodine, and I understand that.
Valentina?
I would follow too, but I will also, it's important for me to understand who was the surgeon who operated on that patient, because like if it's coming from a surgeon whom I really know well, and I know their style, and I know what to expect, and I know their quality of work, I will be completely comfortable just to follow that without completion surgery. On the other hand, if it was the surgeon who was whom I don't know what to expect, I know that all sorts of things are possible with this posterior margin. So I will just be careful and maybe looking closer and trying to get more information from intraoperative report, try to understand what did really happen during surgery. But overall, if it's good quality surgery, no need for completion based on the path, based on
Do you guys let the patient sway you in your recommendation here? Because I bet you that this would induce some anxiety.
Yeah, I mean, if you really have equipoise and you're really in a tough spot there, then definitely I put all of it to the patient and let them participate. Even when you have an inclination towards one way or the other, you should definitely tell them about both options because they're going to hear about it. So I would definitely go on both, explain both pros and cons to them and let them participate. But if you really feel one is a better choice, I don't leave them completely hanging. I try to guide them as best I can.
And then just quickly, in terms of deciding to proceed with the completion based on, risk-benefit discussion with the patient, physician-patient discussion, the timing. That was a great article you sent out, Dr. Marciano. Doesn't seem to matter that much, although there is a bit of an older thinking that I still subscribe to for most cases, is to wait about 90 days to potentially reduce the risk of especially hypoparathyroidism. So, but it seems like maybe it doesn't quite matter based on some of the there's mixed literature basically. So
I think there's mixed data, but
yeah.
I think anecdotally, like in my first 2 years, I was so anxious with these patients that I was like completing people really fast. And I anecdotally think it's a lot worse to do it sooner. So I don't do that. I similarly wait for patients who need a completion. I see all these patients in conjunction with our endocrinologists, and we like review all the path. We were probably a little bit aggressive in this young patient who was incredibly anxious. That's kind of our patient population here. Pretty much everyone works in tech and sees about 5 surgeons, just like New York. So that patient, I don't think that we present them the option. I think we really present them our recommendations. We did end up completing this patient. They did not get iodine, and they followed their TGs, which have been undetectable. So they've done really well.
Awesome. Thank you. Yes, same thing in Tampa. Do we have any more slides for this case, Seda?
I just want to point the decision about completion, the timing of completion should not be driven for timing for radioactive iodine. There is never rush to give radioactive iodine earlier. It can always wait for a couple of months. So there is no need to push for earlier surgery just because we want to give RAI earlier.
Perfect. That's great summary.
Thank you.
Well put.
Excellent.
That's
Great
very
case.
I think highlights a lot of great important, features that we all see very commonly. Excellent case. Do we have any questions? I know we had 1 or 2 in the chat there, but if anybody has any questions about this particular case, feel free to chime in now before we move on to our next one.
I thought I could show one thing really quick.
Yeah.
Let me see if I do this right. So when you look at the ATA guidelines, can you guys see this document?
No.
Forget it.
Are you sharing the rainbow table?
Does this work? You see anything or no?
Oh, yep. Yes.
Oh,
Okay.
yes.
So when you look at the ATA guidelines, it's really hard to figure out what the risk groups are, the way it's set up. So this is a document that Mike Tuttle put together. He's going to write it up to date. It's not been published yet, so you can't really share this. But this is going to be coming out in the up to date. And he and the co-authors there put together what constitutes low, intermediate, high, and high risk. And I thought it's really good that they're separating now PTC from follicular because they're different and they also have invasive encapsulated variant PTC here. But take a look at this one that comes out. It's just really clear because when you look at the current ATA guidelines published in Thyroid, it's so hard to figure all this out. And the case that we just saw, it follows here where it says low intermediate risk. It says here's margins negative or positive at the posterior margin R1. That's what we just presented, which is why it was pertinent for you to bring that up. It was a very smart idea to bring that up, and the completion is completely reasonable. Just because that's not what we do, I would do here. It doesn't mean that it's wrong. But the guidelines are still guidelines. The guidelines are not rules, and so just because it's written in a guideline doesn't mean that we should feel compelled to follow everything to the letter. But
thank you for sharing that. Yes, I think there's one question here, and Dr. Wong, I'm going to put it to you because you had mentioned it. If you're doing a TG on patients who've had a lobectomy only, how do you know when to do any more workup or intervention?
So this is controversial. Some people don't believe in this because there's natural fluctuation of TG with an intact lobe, and we all know this. It goes up and down with the TSH, and so What we're looking for is something catastrophic. We're looking for like a real jump that's out of the ordinary, not like 1 or 2 points higher, but something that's a trend that's going up where that'll prompt like distant imaging. This might be reasonable if you have like some kind of follicular lesion or a follicular variant of PTC or follicular one where you're worried about the small chance of distant mets or RAS mutated cancer. So for that reason, we do check it, even though it's not likely to be sensitive for any small local recurrence. It's more for that rare catastrophic event where you have something brewing distantly.
Awesome. All right. Great discussion. Excellent case. Important points. We got to keep going. So next up, we have Dr. Thornton and a case from Dr. Dillon, Johns Hopkins.
Okay, great. Can you see my screen?
Mm-hmm.
Okay, great. My name's Annie. I'm one of the PGY3 residents from Walter Reed. I spent the last 4 months with Dr. Dillon, so thank you for having me tonight. I will be presenting a moderate case complexity on another PTC. So this was an 85-year-old male who presented back in August with a 3.5 centimeter right thyroid nodule. It was incidentally found during a hearing aid consult with a community ENT, and he had an outside biopsy of his nodule, and it was proven to be PTC. It was BRAF V600E positive on Afirma testing. And on presentation to Dr. Dillon's clinic, he was completely asymptomatic. He had no history of radiation exposure. In terms of past medical history, he has coronary artery disease with 2 stents in place on 81 milligrams of aspirin. His type 2 diabetes on metformin. He's been hypothyroid for the past year on a stable dose of Synthroid. He has hypertension, hyperlipidemia on amlodipine and lisinopril, and he had no relevant head and neck surgery with no past issues with anesthesia. On initial exam, he had a very palpable right thyroid nodule that was firm and fixed along the trachea, but his voice was strong without breathiness. His clinic scope was essentially unremarkable. Dr. Dillon's clinic ultrasound showed a 4.2 by 2.6 by 1.9 centimeter nodule with microcalcs and irregular lateral borders. It was very difficult to ascertain the strap musculature and the interface between the trachea and the thyroid on the right, and there was minimal to no thyroid tissue on the left. There was one lateral lymph node with microcalcs in level 3 on the right, and it was hard to ascertain the central neck nodes. He had a formal neck ultrasound a few days later, which showed indeterminate right level 4 lymph nodes and an indeterminate left 1A and 2A node. He had a CT neck that same day, which I'll play, and it shows this large right thyroid nodule, which was measured 4.4 by 4 by 4.3 centimeters with several internal calcifications and no obvious concerning neck nodes.
Very fishy looking there on the cartilage.
Agreed.
All right.
Agree.
He went a biopsy of those neck nodes. There was one positive left level 2 neck node, and the thyroglobulin wash was notably positive.
Just real quick to point out, thyroglobulin wash for suspicious lateral neck nodes and papillary. What's the importance of that?
It can confirm your suspicion, essentially.
Yeah. Sorry, I don't mean to put you guys on the spot.
Well,
there's a
high rate of sometimes an indeterminate cytology, or you can get mixed up with the lymphocytes, right, in a lymph node, and you may not be able to pick out if it is papillary, but the thyroglobulin be more specific. So it's a good indicator of thyroid cancer within the node.
Yeah. So anytime you're doing an FNA in this case when you're suspicious of papillary, I'd recommend adding that on. All right, next slide.
Just be mindful, just one comment, if the patient has thyroglobulin positive antibodies, thyroglobulin washout may be false negative in that lymph node. So just be mindful, if it's negative, it may be due to antibodies too.
Caitlin, just because we have a lot of fellows, can you go through how you do one, how you interpret it, anything else you do at the time of a thyroglobulin washout? Because I think that'd be helpful for the fellows.
You mean it technically how you do an FNA?
No, just how you do the whole thing. Because I think most people don't know how to do a thyroglobulin washout.
Oh, I'm not sure I've done that since fellowship, Tony. We have the IR guys do it, but Valentina or Rich, do you guys want to comment on that? Like the technical part? Do you
Our
guys do those?
cytologists do it for us. All of our cytologists do ultrasound and needle biopsies, and so we
Yeah.
gave them up a while ago.
Yeah.
Okay,
Tony, what did you want to point out?
I'll answer my own question. So it's just an FNA. You do the FNA and you put it in 5 cc's of normal saline, and you do not send it to pathology. You send it for biochemistry for a thyroglobulin, and it's entirely useless unless you also order a serum thyroglobulin at the same time. And this is particularly true for patients who have their thyroid gland intact, because you may be sampling a vein or a vessel, and you may have a positive thyroglobulin, but it's their serum thyroglobulin. And what you're looking for is a massive difference in ratio. So it's not a very complicated test. It's your FNA. You do FNAs in the clinic all the time. Most thyroid surgeons do, or most endocrine surgeons do. And you just send it in 5 cc's of saline for biochemistry, and at the same time you send the patient to the lab for a serum thyroglobulin. All right, and it's not just a Canadian problem that we got to do our own thyroglobulin washouts. I think
I was
it's
like,
a good.
wait a minute, do you guys not have that there?
Yeah, definitely doing my own thyroglobulin washouts.
No.
Very useful in the recurrent metastatic setting when the thyroid gland is not in place. A little bit less useful when the entirety of the thyroid gland is there.
Very helpful. Thank you. Excellent. Okay, let's keep going.
So would you like to discuss surgical options from here before I reveal what we did?
Sure. Do you want to just summarize real quick? We have what we have. We have a X-size papillary with where the neck disease
So
is.
it's a greater than 4 centimeter right-sided PTC with a positive left level 2 lymph node.
Contralateral.
Okay, interesting. Dr. Wang, what kind of
It's weird.
surgery?
The contralateral thing is weird. It makes you worry that there could be other nodes that are missed in the central compartment or even on the right side. And I saw the negative needles yet on the right side, but the tumor is right-sided, so it's a little bit worrisome. And so obviously, because this, as Caitlin said, it's a little fishy on the thyroid cartilage, you'd be thinking total thyroidectomy. Most likely this might be an iodine case, given its size and possible extrathyroidal extension. And then, obviously, if you work out the nerve, if everything goes well, you do the total thyroidectomy, and then clearly the patient needs a left-sided neck dissection. The thing is that it's kind of weird that it's a right-sided lesion, you're doing a left neck, so then you're wondering, you should really inspect the central compartment, probably needs a central compartment dissection at the same time. So it's a little strange.
Mm-hmm. All right.
This is the patient this is the patient with looks like appears to be more aggressive thyroid cancer at presentation. So at the time of the staging imaging studies, if the CT of the neck is obtained, I will have pretty low threshold to order CT scan of the chest, particularly with BRAF positive, to ensure that there is no pulmonary involvement and mediastinal lymphadenopathy too.
Yeah, so CT chest was obtained and it was negative.
For Dr. Dillon and Dr. Thornton, did you have any discussion with them preoperatively about management of the nerve and the cartilage?
Yeah, that's actually what I discussed with him, but also with our own tumor board, because on top of the fact that this was somewhat of an incidental finding and he's asymptomatic completely with normal laryngeal function, he's 84, history of coronary artery disease with stents. And if we're talking about the surgery that Dr. Wong is proposing, that's about a 9 to 12-hour surgery under anesthesia at one time. And so we had a very lengthy conversation about his goals and the oncologic goals and ultimately the quality of life, because like I said, he's functionally completely. So yeah, it was a very long conversation. Actually ended up having 2 conversations with him about it just to confirm his desires. But ultimately he wanted all gross disease that was on imaging or clinically relevant removed. But how we went about doing that was the question.
Okay, let's do our next slide.
All right, so intraoperatively, we planned for a total thyroid with bilateral central necks and bilateral lateral necks. However, intraoperatively, we found several concerning findings. He had an infiltrated tumor that extended to the inferior constrictor and it involved the cricothyroid muscle. There's no cartilage invasion, so we took a cuff of muscle with the right lobe and got an R1 resection with that. The right-sided nerve was not encased. It was adherent to the tumor and peeled away. So after the right lobe was taken out, the right central neck was completed, and the left central neck was completed. We went to re-stim the the right nerve at that point, and the stim was lower than before we started the case. So at that point, Dr. Dillon, do you want to take it away?
Oh,
Do you
just
remember do you remember what the amplitudes were? Like the starting amplitude and then the final amplitude, like the lowest it was?
Yeah, I mean, I don't have my op note offhand, but just to clarify, our plan, given the disease, was actually a total thyroid bilateral central and a left lateral neck. He didn't have right lateral neck disease. And then based upon the findings of the right lobectomy, which was basically effacing the cricothyroid cartilage with no invasion, but I knew that SLN was gone because the cricothyroid was gone and the inferior constrictor, we had to take a cuff. The right recurrent stemmed really well after the right lobe. So I ended up doing the right central neck at the same time. So I didn't actually end up doing the left lobe until after I completed the right central neck. And so we had a stem throughout the entire case. We had a pretty, it was over 500 that I can recall, and it remained that way. We ended up going to the left lobe, and that was as in the imaging showed, there was really no thyroid tissue. Unfortunately, the nerve was very compliant, so we did that in the left central. And at that point is when Dr. Thornton mentioned we went back to the right side to figure out stem. It didn't drop 50%, but it was lower in the hundreds than I wanted it to be. So we ended up actually not completing the left lateral neck at that time. And so that's kind of where we left it with the patient. Now, there was stim on both sides at the end of that case, but I wasn't very happy with the change on the right.
Let me just summarize the findings and the outcome here, because I think it's a little bit, just to be totally clear. So we did the right thyroid lobe and the left thyroid lobe. So the thyroid's completely removed, but the right nerve is not working as well as we like. And so we've deferred the left lateral neck dissection because of some concern about injuring the vagus and ending up with a bilateral vocal cord paralysis.
Correct.
Okay, so I just want to make sure that's clear for the fellows of why exactly we're not doing the left lateral neck dissection. So there's a lot of interesting intraoperative decision making happening. Dr. Wong, if you do one side of a total thyroidectomy, planned total thyroidectomy for cancer, and you are dissecting tumor off the nerve, you lose stem, what goes into your mind when you're deciding whether or not to proceed with the other side?
Yeah, it's such a good question, Caitlin. The first thing is you want to see if it's the loss of stem is real or not. So you can have loss of stem for many reasons. It could be that the tube gets torqued, the tube gets pulled back. You're working and by pulling on it, you could have temporary paresis. You could have long-term paresis because you're rough on the nerve. So what I do first is I take a pause. I check the tube, make sure that everything is plugged in properly, and then do a little stim. If I can't get any kind of signal on the nerve, I just do the cricothyroid twitch palpation. I just hook my finger behind to the PCA, and then you touch the nerve. And if you feel a little twitch, you know it's intact and it's a system problem. If you can't feel a twitch, then you know it's really down. And if it's really down, you look at the number, you see what the amplitude is. You should know what it was to start with, and you see what the number is. If it's like 99, then you wait like 5 minutes, and it's back to 110, and you get a beep again. But there's nothing magical about 100. 100 is what most people use as a threshold. That's just a cutoff. But then if I really do lose signal, then I usually stop. I honestly usually stop and I do something else. I don't work on the nerve. If I feel like I was really good on the nerve and I feel like I don't think I really did anything bad, sometimes I'll go do something else without pulling on the nerve. I'll work on a different part of the thyroid, like where there's no tension on it. And then I'll re-stim it a little bit later. It could be 10, 15, 20 minutes later. And if you have a temporary paresis from traction, sometimes it comes back like right away and you're like, oh my God, it's okay again. But then you have to be like super careful with how you're holding the thyroid and not yanking on it, because it's most of these injuries are not like traumatic sectioning or cutting or anything or burning. It's usually traction from pulling. The poor nerve is getting yanked up, and you just have to relax and let it recover. And if I can't get it to recover and it's really down, then I stop. I stop usually.
Yeah, I think that's a key point, to take a pause, troubleshoot, stop if it's really out is never the wrong answer. We're dealing with papillary thyroid cancer here, not squamous cell or something else like that, and they're still going to live a long time even if you had done nothing originally, right? So you don't want to have them end up with bilateral vocal cord paralysis over this. So there's different ways to handle it. Sometimes people think about their own personal rate of nerve injury, if the risk benefit of going to the other side. One other tactic that sometimes people do is if you start to see that one side might be potentially at risk, going to the normal side, doing that one and getting that nerve out, feeling confident that you can be a little more aggressive on the tumor side. So there's several ways to handle it, but really just doing what you can to avoid a bilateral cord paralysis. Let's go to the next slide. We want to have time for Dr. Jethwa's case as well.
Right. Pathology showed what we expected, PTC in that right thyroid lobe measuring 4.2 centimeters. In the right central neck, there was 3 of 9 lymph nodes that were positive. Left central neck, the nodes were negative. That is our last slide. He
Thank
is
you.
he is scheduled for a left lateral neck dissection in December.
So did his nerve, when he woke up, was his nerve okay?
Yeah, he ended up having good mobility, but I'll be honest, he has an SLN paresis. And the nuances of that, I mean, he's already had some voice change, which he can function with, but there is some, it's not a paresis picture, but it does cause dysfunction. So, I think it's important when we're thinking about lateral neck disease doesn't kill us, right, with papillary, but if we do hit the vagus, we can cause more dysfunction even to that recurrent. So, you were going for the stage surgery. He's willing to go through that, but it's still weak, but we're waiting for it to see if there's going to be any more kind of synkinesis. But if not, he's okay with proceeding with the mobility that he has. So it's not a perfect picture, but I think from a quality of life standpoint, this is what, this is the best thing for him at his age and what he wants.
Yeah. Older people tend to be much more sensitive to those nerve injuries. So
yeah.
Great case. I think the keys for this one are, what do you do when you suspect nerve paresis intraoperatively for a cancer case? So I think there's some great pearls from that discussion. Thank you. Let's go to our last case. Dr. Jethwa from the University of Minnesota, pivoting a little bit to medullary thyroid cancer.
All right. Do you guys see that there?
We do.
All right, cool. Yeah, thanks all for the invitation of presenting this medullary thyroid cancer case that I've been taking care of this young man for the last year or so. So he's 17. His past history and social history is pretty much unremarkable, only due to the fact that he never sought great medical care, but he presented with abdominal pain, diarrhea, and weight loss that had been persistent, presented to our pediatric hospital for EGD and colonoscopy. During that procedure, had a challenge with ventilation during the procedure, and then immediately in the recovery, to develop significant respiratory distress, and our pediatric otolaryngologists were called urgently. They were able to intubate him with a size 5 endotracheal tube. At that point, they scoped through the tube, and this is what they saw. So obviously significant compression of the trachea. The patient was stable enough with the size 5 endotracheal tube in. They elected to get an urgent CT neck and chest on their way to the operating room for more definitive surgical area. But this is what the initial CT scan showed us. and I can just walk briefly through this, but clearly a pathologic lymph node in the right lateral neck. There's a level 2 node there. You can see this thyroid mass here with significant compression of the trachea. And you can see the common carotid, at least in this view, probably just shy of 180 encased. And then further down, you'll see that the innominate is completely encased in this tumor. So their plan was proceed to the operating room for a trach and biopsy the thyroid at the same time. So that is what they did. And pathology showed medullary thyroid cancer. So this is when I was called. So I think we can just pause there and talk a little bit about what we would all do at this point.
Yeah,
I'm happy
some
to provide
basics.
as much information as needed for the history.
Yeah, why don't we go through some of the basic workup for medullary thyroid cancer? Ashok, what do you guys usually do for like the initial package?
Yeah. So, the full lab workup. So TSH, calcium, PTH, calcium. I check a calcitonin and a CEA. And then I just do the serum metanephrines to start. I don't typically get the urine metanephrines. That's just what our endocrinologists have recommended to me. In terms of imaging, I'm definitely a huge fan of the ultrasound. So I do my own ultrasounds in clinic. So thyroid, neck ultrasound. For the medullary patients, they do need some type of cross-sectional imaging. I think that the exact modality used is a little up for debate. Our radiologists do prefer using the dotatate PET. So we get the dotatate PET. FDG PET I think is fine as well. We do the genetics on the tumor, so testing for RET on the specimen. And then all these patients should be evaluated, in my opinion, by genetics for whole blood testing. So that's what we do here at the University of Minnesota.
Thank you. Yeah, I think just to summarize some of that for the fellows, medullary thyroid cancer can be part of inherited syndromes. So they need to be referred to genetics typically. And then while you're waiting for all that, doing the testing for some of those syndromes like MEN syndromes, having calcium, PTH, screening plasma metanephrines to make sure they don't have any kind of pheochromocytoma. Dr. Teresova, anything you want to add to that for initial diagnosis of medullary thyroid cancer?
No, I think that it definitely completes the workup. That's what we will do. If, let's say, if it will not PET dotated, it's not available, we do CT neck, chest, abdomen. Very important to assess the liver because that's the most common site of this metastatic spread for medullary thyroid cancer, and it's typically MRI of the liver or three-phase CT of the liver, and then evaluation of the bones. So if you do just CT of the neck, thorax, abdomen, and pelvis as a baseline, that's not complete the staging. You need to evaluate the bone, whether it's going to be bone scan or PET dotatate scan or FDG PET, like either of these modalities.
And in terms of the genetic testing, also to be very clear for the trainees, we're talking about both germline and somatic testing. So germline looking for MEN2 syndromes and looking at the tumor itself to see what mutations it has, potentially something actionable. And they get a ton of imaging and a ton of blood work. So Dr. Jethwa, what's going on next?
Sure. So here is his labs, notably, you can see the calcitonin over 11,000. The rest of his testing, fortunately pretty normal for him. Like I said, we did the dotatate PET. He had that right level 2 node that I previously showed, no other evidence of regional disease, multiple small pulmonary nodules that were read as indeterminate, nothing else in the rest of the body. And then his genetic testing. So
that makes sense because it's so rare for a 17-year-old to present with such advanced MTC. Most of the sporadics happen in older patients, or if there are some germline mutations where patients will present later in life, usually with the less aggressive ones. But the 918 is one of the more aggressive types that you can have, both as a somatic and both as a germline mutation. So the fact that he's 17 and has so much disease, this kind of makes sense.
Yeah, I agree.
But the fact that there's a RET mutation at the same time is good because only about 60-70% of the somatic mutations have RET mutations, and the others are mostly RAS and others. So with a RET mutation, it offers some therapeutic possibilities at least.
And the risk of pheochromocytoma with the RET9 germline pathogenic RET M918T is about 50%. So that has to be evaluated really clearly. And if you really need to assess it urgently, you can just look at the adrenals on the CAT scan and see evidence of adrenal nodules. That will increase the pretest probability. Plasma mets are frequently false positive. So if in doubt, need to confirm with 24-hour urinary CATs and mets and look for medications would interfere with the measurement of this tests.
Very helpful. And I think just to hammer home this particular mutation, do you guys know when we would need to do a prophylactic thyroidectomy if this was already a known mutation in the family history? Dr. Wong, do you do much I don't know if you guys do peds,
I don't do a lot of the pediatric
we don't
stuff,
either.
but I'm a firm believer that we should be doing this over the pediatric surgeons because we do like almost 1,000 a year here, and the pediatric surgeons do like 5. So I keep saying that we should be doing these, but this is one of the highest risk category where by guidelines you think about it like what is it below age 5 or something, or it's like
even
age
first
one.
year of life.
Oh, first year of life,
Age 1 for this one, yeah.
But honestly, to operate on someone that's below 1 is really harrowing. I mean, that's not something that I do regularly, but the people that do this, the parathyroids are like impossible to find.
Yeah,
the nerves are like nothing, so it's really hard. It's really hard to do that.
But it just goes to show for the trainees, if you know that this patient has this inherited mutation, this is somebody that gets a prophylactic thyroidectomy early in life. All right, next slide, if you want to keep going.
Sure. Oh. So, when he was so malnourished, his BMI was 13. At this point, when I met him, he was trach dependent, could not tolerate capping. As I showed you that the bulk of that disease was on the right side, but he had a left cord paralysis when I met him. The right side was actually functioning normally. And that's, those typical mucosal neuromas you see in MEN2B. And he did have all the characteristic bases, but somehow just was not detected in his childhood pediatric evaluations. Yeah. So then, just going through some of the different treatment considerations, discussing neoadjuvant considerations. What is the extent of surgery? Do we go ahead and do elective lateral necks? Obviously a disease on the right neck, but a lot of controversial topics in this case.
Yeah, for sure. So I think that's the point of this case is that there are a lot of nuances. It's complicated. I think we can all agree, though, that with a nominate encasement like that, this is not a surgical case up front. Unresectable. So what do we do for unresectable medullary thyroid cancers? Dr. Teresova, what kind of options do we have?
So in this specific case, the presence of red, somatic, and germline, obviously, mutations opens opportunities for selective RET inhibitors, and they change the landscape of management for patients with medullary thyroid cancer. They are very well tolerated. It's basically, initially, it was selpercatinib and pralsetinib, but the selpercatinib is the only one that is approved for the treatment of medullary thyroid cancer, RET mutant medullary thyroid cancer. So that could be used as a neoadjuvant agent with great tolerability, great response. And so I think that that's something that could be considered.
I think, Dr. Wong, you probably have more experience than I do with neoadjuvant, but if it's clearly unresectable up front, it's a little harder to call it neoadjuvant, right?
Right. That's right. So the whole idea of neoadjuvant is that you're planning to do surgery and you're using the selpercatinib as a modality to get some regression to make the surgery less morbid. If it's clearly unresectable from the start, like if the innominate is completely encased or if the trachea is extensively invaded and you would have to do some kind of laryngopharyngectomy and a innominate resection, then it's really all semantics. Then you could put them on a RET inhibitor just as therapy and see how things go without a plan for surgery. But it's all semantics, really. But it sounds like this is pretty bad. I mean, the trachea looked pretty bad to me, Dr. Jethro. And then the innominate I couldn't even see. I assume it goes much more inferiorly into the superior mediastinum.
Yeah, it did not go too far into the mediastinum, but as you guys saw there, the innominate was totally encased. In very close review of his imaging, there was no signs of transmural tracheal invasion. I, of course, bronched him and did esophagoscopy as part of the workup. There was no transmural invasion. And if time permits, you'll see some imaging coming up of the trachea.
I think we are running short on time. I want to be respectful of everybody's time. Do you want to just summarize for us what happened with them?
Sure. Yeah, so he got sulfatinib. He was on it for 4 months, had a pretty remarkable response. You can see the shrinkage of the tumor in these images here. The innominate was able to get freed there. And so I actually did take him to surgery. I did have a cardiovascular surgery who was willing to resect the innominate if needed. I felt I needed to be aggressive with the 17-year-old, even though with a calcitonin of over 11,000, he obviously has distant disease. It was extremely challenging surgery. The right vagus, remember, left cord paralyzed, right nerve working. The right vagus was encased in tumor. So I was able to preserve that, maintain a functioning right nerve, did the right neck dissection, total thyroid and central neck, but it was extremely challenging. But he's actually done well. He's recovered both nerve function now. I was able to get him decannulated. He is eating everything by mouth, so I got his G-tube out. And his dotatate PET showed no evidence of disease. His calcitonin's ranging around 500. So still disease, but,
Excellent work.
Well, outstanding. And
great job.
Just so you know, Mark Cefario presented at the ATA about 3 or 4 months ago the neoadjuvant sulfatinib study with 4 institutions, and he showed like an over 50% major response rate. And I think in his study, almost everyone made it to surgery, and they had like an over 90% R0, R1 resection rate. So this definitely has legs, and we do it too here. And this is definitely a target you want to go after. So congratulations. That's a fantastic surgery, Dr. Jethwa. Fantastic.
Awesome. Well, thank you guys so much for participating tonight. Thank you to the fellows for joining us. These cases were really great, super educational. We hit a lot of important points. Isaac, I see you have some questions there. I don't think we have quite enough time, but real quick, prophylactic thyroidectomy for MEN2, I think depends on the mutation. There's guidelines for different mutations, and calcitonin levels influencing when you're less eager. So I think Dr. Jethwa commented on that, even though he knew the calcitonin was super high, he probably has distant mets, but still wanted to be aggressive with the local disease. So doesn't make your decision for you one way or the other. Okay, so if anybody has other questions, feel free to reach out to me after the session. Tony, any other housekeeping here?
Yeah, one more piece of housekeeping. Our next session's a month away. It's the first Wednesday of the month. It's going to be about skin cancer. Neil Gross and Alan Lynn from the cutaneous section will be running that one. It's going to be a fantastic session. We're looking forward to having you all there. Really big shout out to Caitlin and really everyone involved, Valentina, Richard, everyone who presented. Just excellent cases, very educational. And we'll see you guys all at the next one. Take care, everyone.
Have a great night.
Thank you, everybody.
Bye.
Bye.